In version 1, there are three key design elements: the episode definition and the scope of services. We'll talk a little as we go through about principal accountable providers, and we'll talk more about the patient severity levels and exclusions for the patient, the ADHD patient who doesn't really fit into the episode. And there are some exclusions in that area. Episode definition and scope has the first thing that I've already pointed out is that the episode is a duration of 12 months. Because it is really a medication concordant, is the guideline concordant care, then the episode needed to be longer in order to be able to see that medication is titrated and given effectively. The start of the episode for new patients who are just coming to you, the episode begins on the date of the treatment initiation. For recurring patients, after this first year of episodes, then the new episode starts on the date of the first treatment after a previous episode ends. For example, the very next office visit or the very next time that a prescription is refilled. And then also to remember is that any ADHD treatment as defined by a primary diagnosis with an ICD-9 code for ADHD is included in the episode with the exception of the initial assessment CPT code. And that's really, we want to be sure that we're encouraging appropriate initial assessments, so it is excluded. The PCP, a psychiatrist, or a licensed clinical psychologist is eligible to be the principal accountable provider. For version 1, the RSPMI provider organization will be the official PAP when listed as the billing provider, but the reporting will be provided at a clinician level where it's available. That way you'll be able to track who really belongs to those clinicians within your organization. If a licensed clinical psychologist treats the patient, then a COPAP is also required, and providers will share any gain or risk sharing that would occur. Patient severity levels and exclusions. The ADHD episode includes patients aged 6 through 17 who do not have behavioral health comorbid conditions. Children under the age of 6 will continue to be paid fee-for-service just like they always have. They will be dropped from the episodes. The next slide goes through the included ICD-9 code for that matches for ADHD, and again tells that the episode duration is 12 months. I believe everything else we've gone through here. And now Dr. Miller will discuss more about the medications as it relates to the episode.
Well, so here we have the initial list of medications for which the cost is counted against overall episode cost. And as we've been saying, the primary treatment for ADHD, evidence-based treatment, is medication. And here's a list of stimulants. Some of these are on the preferred list. Some of them are non-preferred. We'll get into that a little bit later. But this is a list of medications. And again, we're talking about children ages 6 to 17. Now, we're drilling down a little. I don't know if you've seen this chart before. Hopefully you have, and hopefully you can see it. But we wanted to get a lot of questions about the medications. And actually what this is on the there are 3 columns. On the left 2 columns are the preferred long-acting psychostimulants. And there's been a benchmark cost of $140 for 30 pills or patches has been arrived at in developing this episode. So if you're using one of these long-acting stimulants and it's one a day, the cost would be $140. This is the cost that was arrived at. It's not really the actual cost, but it's a cost that felt was appropriate for this episode. If you look on the right-hand column, those are short-acting preferred agents, and those are billed at the actual cost, which you can see there. For the majority of patients, and I know there's discussion about this and sometimes disagreement, but the majority of patients in this age group, hopefully a long-acting psychostimulant would be sufficient to help them get through the day and into the evening hours. The half-life on most of these is quite long, and I know that a small amount of the children might need a short-acting to help them along, but majority should just need one long-acting psychostimulant. On the next page, which is a lot of numbers and figures, these are the non-preferred medications, both long-acting and short-acting, and these are the medications that would actually be the actual cost would be attributed to it, as you can see listed throughout. I wanted to just be clear about this in terms of what's preferred, what's non-preferred, and as we've talked about in the past, some of the medications that were preferred are no longer preferred because the pharmaceutical company did not send in a contract and a bid. So by established regulations and rules, they cannot be preferred. And I know there's been issues with Concerta and Strattera, but neither company put in a bid that was at all, and we could not accept that. And so they had to go to non-preferred status. And we can answer more questions about medications as we go along.
The next series of slides, a couple of slides, really goes over the principal accountable providers. It's again a good overview and the criteria that was used to establish who could be principal accountable providers. As you can see in the blue box, it discusses there are 2 types of providers for an episode of care. The first is the principal accountable provider, and the other is other participating providers who may have a role in caring for the ADHD patient, but who does not have the actual responsibility of being the quarterback or of the care for the patient. To talk a little more about the principal accountable provider, the provider who has the principal accountable provider is someone with which the payer directly shares the upside or risk for cost relative to the benchmark. The principal accountable provider can expect to receive performance reports and is the person who organizes the team to drive performance improvement and may be a physician practice, a hospital, or another provider. And these are general guidelines and criteria across all episodes. So this slide is a little general. Other participating providers are any provider that delivers services during an episode that's not the PAP, and are payers that are who do not directly share in the upside or risk for costs that are relative to a benchmark. The payers will identify 1 or 2, if necessary, principal accountable providers for each episode of care. This model focuses on accountability, ensures sufficient upside or downside to motivate behavior change, and simplifies the administration of the episode. Qualifications for the principal accountable provider include decision-making responsibility. The PAP is generally the person who selects tests and screening, determines the treatment approach, and carries out procedures for the episode. They have influence over other providers. They are the provider who is in the best position to coordinate with, direct, or incent participating providers to improve performance. They make referral decisions, provide infrastructure, and organizes quality improvement efforts. The economic relevance is that is the provider who bears a material portion of the episode cost or a significant case volume. Principal accountable providers who can be the PAP. People who, in ADHD specifically, who can be the PAP are primary care physicians, inclusive of pediatricians and family practice physicians, psychiatrists, whether in private practice or within RSPMI provider organizations, licensed clinical psychologists who are in private or individual practice, but they do require a COPAP in order for prescriptions to be written correctly. The RSPMI provider organization itself can be the principal accountable provider. One thing to make sure that I want to make sure everyone understands is that providers will continue to bill their claims in the same manner today as they always have. They follow their program rules, provide their services, and bill their claims. The risk and gain sharing is a retrospective look and an average, based on an average of costs. Those who are eligible to provide care but cannot serve as a PAP in this first current version are advanced practice nurses, licensed clinical social workers, school psychology specialists, other licensed mental health professionals, and mental health paraprofessionals within RSPMI organizations. All providers are currently eligible to go ahead and provide their care and will be eligible under the episode model and will bill claims again in the same manner as today. So that would be the takeaway from this slide, is that we are not changing our current billing methods or our current programs, but we'll be taking a look back at the episodes to ensure that they come within the ranges established for guideline concordant care on the thresholding. Principal accountable providers attribution logic. So here's the logic that kind of went into the clinical work group's decision making for this episode are that only physicians and licensed clinical psychologists are eligible to serve as the PAP. Clinical psychologists in private practice require a COPAP with the ability to write scripts. If only one PAP-eligible provider treats a patient, that provider is automatically assigned as the PAP. If a patient is treated by clinicians billing under an RSPMI organization, then the RSPMI billing organization is assigned to be the PAP, but where possible, reporting will identify individual clinicians within the PAP who provide the treatment. If a patient is treated by a licensed clinical psychologist, Another PAP-eligible provider must serve as the co-PAP, and in those cases, gain and risk is shared equally among all co-principal accountable providers.